So welcome, everybody. I'm really excited to have our guest speakers today speaking about their recent paper, The Unmet Needs of Women with Parkinson's. And the reason I'm really excited is, number one, Indu Subramanian. Oh my goodness, I left you at the end off of your name. Somehow it got lost there. Indu Subramanian, it happens to be my doctor, and I've been with her for 13 years, and trying to bring up all of the stuff, the information. Okay. She is at UCLA. She went to medical school at the University of Toronto and did her movement disorders training at UCLA. And she's been there ever since. And she is also the director at the VA in West LA of the Parkinson's Disease Research, Education, and Clinical Care Center of Excellence in Parkinson's Disease at the VA. And she's into all kinds of things. That's all I could go on and on and on about her. She's into integrative medicine with special interest in yoga and mindfulness. And I think we bonded over yoga the first time I met her, because I was doing yoga all the time. And I credit yoga with keeping me flexible and able to move. It's really made a big difference in my life. In the last 6 weeks since I broke my shoulder, I haven't been able to do it, and I'm not sure when I can go back. So looking forward to that. So she is designing a yoga training, teacher training program for yoga instructors interested in working with patients with Parkinson's. And she was recently board certified in integrative medicine. And it goes on and on and on. She has 3 teenage boys. She is the internet queen on Parkinson's PMT Alliance, and she's everywhere. And Adrienne Keener was my co-chair, my local co-chair for Women in PD Talk about 4 or 5 years ago. And when we first started talking about unmet needs of women with Parkinson's disease, she went to USC for medical school and then changed colors and went to UCLA for her residency, and has been there ever since, and also works at the VA. And she has 2 little children, 1.5 and 6 years old. So I want to welcome both of you, and really excited to have the 2 of you here today. And I'm going to pin, let's see, where are you? Now I have to find you. Okay, I'm going to ask everybody to mute yourselves, or please. And okay, Adrienne, let's see, add pin. Okay, there we go. Now I have both of you. All right. So welcome. I think what we're going to do today is Adrienne and Indu are going to do a conversation. You're going to talk a little bit and then open it up for questions. And just a real quick thing. One of the most important things I think that has come out of this is that they have taken what we did 5 years ago and really expanded what we learned and brought it all together. And your 15 secrets of women for women with Parkinson's is terrific. And I especially like number 13, which says you will do better if you have a tribe. Social connection in Parkinson's disease is huge. And that's what we are doing here on Sunday mornings, ladies. We are connecting. And I know that a lot of you have made personal connections with other women through this, and it's amazing. So with that, I'm going to open it up to the 2 of you and take it away.
Great. Well, I know as physicians who care for people with Parkinson's, and as women in our own roles in society, we're so thrilled to be speaking to all of you, and to any men also who might be watching this or participating too, because we all really need to work together to empower the voices of women with Parkinson's and to really improve care for everyone with PD. So we're going to share just a few slides here reviewing our paper. Dr. Subramanian will share those 15 things that Sharon alluded to, and then that should open us up for some good opportunity for question and answer. So we'll try to save plenty of time for that. So I'm going to share my screen here. And Indu, I don't know if you want to make any introductory comments.
Yeah, no, I mean, I think it's just a lovely gathering that you all have. We're excited to be here and continue the dialogue. And I know there's been an energy here, and I think we want to keep the momentum going so that we can really sort of change things for, as Adrienne said, not just women, but everyone living with Parkinson's. And as women, we obviously care about our women patients and those who we've gotten close to over many, many years. And so we sort of are thrilled to be here and happy to answer questions as well.
Yeah. All right, so let's kick things off here. So just to give you a brief graphic overview of what we're talking about today. So who has Parkinson's disease? So about 60,000 Americans are diagnosed with PD each year. And while we know that the risk is a bit lower in women compared to men, women still make up a huge number of people living with Parkinson's disease. And very interestingly, there are probably some racial and ethnic differences in that ratio between men and women with Parkinson's disease, with several studies out of Asia demonstrating that the ratio is a bit more equal. And that might be attributable to different factors such as genetics, environment, or even the way that they're ascertaining cases of Parkinson's disease in that region. So just to give you a graphic view here of why it's important, why we need to focus on women with Parkinson's disease, what we can learn from perhaps the lower risk that women have that might benefit everyone with Parkinson's. So as Sharon mentioned, I had the great fortune of working with her and another one of our co-chairs here. This is Ali Elder, a physical therapist who specializes in Parkinson's disease as the regional leaders for the Parkinson Foundation Women and PD Talk initiative. And this, really was a great opportunity to hear from women living with Parkinson's disease about what their needs were, where we were falling short as a scientific community, and a great sort of way to come together across the country to share what we learned. And so this is a photo from that national coming together to share what all the different regional teams had learned through this effort. So the goal of the Women in PD Talk initiative was to identify research questions to further elucidate gender differences in Parkinson's disease, raise awareness among clinicians, scientists, patients, and the public, and develop tailored interventions that meet the unique needs of women and men with PD. This led to the publication that came out this January, spearheaded by Dr. Subramanian, with the senior author Elena Moro, who's a movement disorder specialist in Italy, who's done a lot of work looking at gender differences in movement disorders. And very importantly, we felt featuring also the voice of 3 women living with Parkinson's disease as our co-authors. And so this was published in really what's the premier journal in our field in movement disorders, trying to reach sort of a broad audience of clinicians and scientists. And we're also happy that this article is now open access, meaning even anyone in the lay public could also access the article and read it. So we're going to review a little bit about the findings, major findings from the article. So what causes Parkinson's disease? This is a huge question, and one that people who are newly diagnosed often ask, why did this happen to me? And it's something that we don't fully understand. So we know that purely genetic, biological, or environmental causes of Parkinson's disease are quite rare. And more commonly, we think about the cause of Parkinson's as a combination between these factors. And so the common environmental factors that we might think of include things like pesticide or heavy metal exposure, traumatic brain injury, head injury is another risk factor. And so it's possible that some of the differences we see in women may be attributed to the fact their environmental exposures and risks are different than the ones that we see in men. About biological factors, well, we know that age is the largest driving biological risk factor for Parkinson's disease. And when
I'm
you look
listening
at
to my webinar, but I'm back.
the differences between men and women with PD, you obviously come to think about hormones. But there are probably other biological differences well beyond hormones that influence the risk of Parkinson's disease and the differential risk between men and women. But let's talk about estrogen, the major female hormone. So in preclinical models of Parkinson's disease, meaning looking in mice who have Parkinson's, we see that there's a different effect of a toxic chemical called MPTP in men compared to women mice. And also we see that estrogens have an anti-inflammatory and anti-apoptotic effect. Now this means that estrogen seems to protect cells in the brain from inflammation and from cell death or turnover. We also see that estrogen can inhibit the aggregation of alpha-synuclein, which is the abnormal protein that clumps up in the brain in people with Parkinson's disease. So in direct scientific models, we can see that estrogen is protective. We also see in looking at epidemiologic studies of Parkinson's disease that women who have a higher lifetime estrogen exposure have lower risk of Parkinson's disease. I'm involved in an epidemiologic study here in California's Central Valley, the UCLA Parkinson's Environment and Gene Study. And we have shown in that population that increased menopausal age is associated with reduced risk of getting Parkinson's disease. However, there are some conflicting data in this area. We also see, looking at studies of women taking hormone replacement therapy, that the timing and duration of that hormone exposure may be critical factors. So there's some conflicting data based on when and what type of hormone replacement is used that you may have a higher or lower risk of developing Parkinson's disease. We also believe that hormones may modulate other common risk factors for PD. So caffeine consumption, for example, is linked to a lower risk of Parkinson's disease among men, but we don't see that same association in women. And NSAID use, this is medications like ibuprofen or naproxen, for example. That class of medication is associated with a lower risk of Parkinson's disease in men, but actually a higher risk of Parkinson's disease among women. And then other class of medications used to lower a chemical called urate. These are medications commonly used in the treatment of gout. For women, this association sort of varied by age, whereas in postmenopausal women where urate levels are more common, more similar to those in men, then we saw that exposure to these medications decreased their risk of PD, but this did not hold true for younger women. We also know that beyond risk factors for getting Parkinson's disease, that once women have Parkinson's disease, they experience the disease differently from men, from the types of symptoms they have, the treatment responses, and also the access to care. So on average, Parkinson's disease starts earlier in men than it does in women. We see that women tend to be more prone to develop tremor-dominant Parkinson's disease. We also see that women have non-motor symptoms more commonly, including pain and mood symptoms like depression. We also see that in the way Parkinson's disease impacts someone's quality of life, that for women, depression and fatigue were large driving factors, whereas cognitive complaints were large driving factors in men. This is a great visual from an article that was published a few years ago now, looking at differences in symptoms between men and women, as well as some differences in environmental and genetic factors that might contribute to disease progression and onset. Finally, we also see that women experience a unique impact of hormonal fluctuations on their Parkinson's symptoms. So around their time, the time of their menses, women often report worsening of symptoms. There's been some question because of this observation if the use of oral contraceptives or even adjusting your Parkinson's medications around your menstrual cycle might help to mitigate some of this. We also see that Parkinson's symptoms are worse during pregnancy and postpartum for those younger women who experience pregnancy with Parkinson's disease. And we also note that around the time of menopause, women also report worsening of their symptoms. I mentioned earlier the differential effects that the timing and type of hormone replacement therapy might have on your risk of getting Parkinson's disease later in life. But when you have Parkinson's disease around the time of menopause, there's actually one study that showed that hormone replacement therapy might actually improve motor fluctuations in that setting. So this is one of the figures from our paper, really highlighting the different hormonal stages in women's lives, which are obviously distinct to what men experience. And certain considerations that we want to focus on during these different hormonal stages. We also see that women with Parkinson's disease appear to have a higher risk of certain comorbidities, one of which is a risk for osteoporosis and hip fracture. And we know that these types of comorbidities can really have a huge impact on quality of life and nursing home placement in people with Parkinson's disease. So addressing these other medical conditions, especially in women with Parkinson's disease, to prevent things like hip fractures is really important. So should women with Parkinson's disease be treated differently? Well, we do see that women are more prone to develop dyskinesias. We know from pharmacologic studies that levodopa is more available sort of in women compared to men. So the way they metabolize the medication is different. We also see that the genetic determinants of dyskinesias may differ among men and women. So here there are some biological and genetic factors that certainly impact the way that women respond to medications differently from men. We had a brief chat before we formally got started today about deep brain stimulation. We see that women with Parkinson's who receive DBS actually report greater gains in quality of life compared to men who go through the procedure. However, we also see that women are much less likely to receive DBS for treatment of Parkinson's disease. Now, there are several factors that could be responsible, and we really need to understand this better. And those factors might include patient preference or perceived risk of a procedure like DBS. There also may be a role of physician bias, where perhaps physicians are not referring their female patients for consideration of the procedure at the same rates that they're referring their male patients. There may also be other health conditions or comorbidities that preclude considering the procedure, for example. But the bottom line is that the areas of drug safety, drug efficacy, drug tolerance are really understudied for women with Parkinson's disease. The majority of research that leads to new medications being approved and developed in PD has historically been done on men. And so we really don't know how best to tailor our treatments for women. Now, the first step to getting the right treatment, though, is getting the right diagnosis. And this image here is the classic textbook picture of an elderly white man with Parkinson's disease. And this is what we teach our medical students, nursing students, about what to look for when we're diagnosing Parkinson's disease. Parkinson's disease is a clinical diagnosis based on those motor symptoms, and there are a lack of biomarkers. And so it really takes an astute clinician to recognize the signs and symptoms to make the right diagnosis. So a couple of years ago, Mike Oken, who blogs with Dr. Subramanian on parkinsonsecret.org, he and his colleague published this editorial where they said it's time for a new image of Parkinson's disease. So we need to update this 1886 illustration of the elderly white man to include, young women and include all races, ethnicities, genders in recognizing the image of what Parkinson's disease is. Now, we also know that once diagnosed with Parkinson's disease, women are less likely to see a neurologist. And we also know that being under a neurologist's care when you have Parkinson's disease is associated with better outcomes. And so we need to really improve access to care for women with Parkinson's disease. But there is a significant delay, not only in diagnosis, but also in delay to referral. So if you look at the top bar graph here, this is the time it takes from when women first develop symptoms to the time they're referred to a specialist for care. And you can see it's almost twice as long as that experienced by men with Parkinson's disease. When we think about long-term care for Parkinson's disease, we also see that women are less likely to visit a physician for care, more likely to be placed in a nursing facility, more likely to receive home health and hospice care as well. So over the long-term course of their disease, there's also a difference in the care received between men and women with Parkinson's. And what barriers could be contributing? Well, I think one that we certainly see in our practice is that women are often in a caregiving role for others. This includes their partners, their aging parents, their children, even their grandchildren. And there are studies looking at caregiving in general, showing that women in a caregiving role often neglect their own health problems. So when one of those health problems is Parkinson's disease, perhaps women are putting their needs sort of second to those of the people around them who they're caring for. This is a quote from a paper looking at the sort of social impact of Parkinson's disease that I think really resonated with what I hear often from my patients. And this woman said, although I realize that getting this disease is not my fault, it did compromise my roles as a mother of a young child, the daughter of an elderly parent, a wife, and a business partner. So there's also this psychosocial impact of Parkinson's disease diagnosis. We also know that women with Parkinson's are more likely to have to pay non-relatives for caregiving. They're less likely to come to their physician office visits with a caregiver or partner there. And they're more likely to live alone. This is another image from our paper sort of summarizing these differences between the motor symptoms, non-motor symptoms, and I think very importantly, psychosocial issues that women with Parkinson's disease face. So just to wrap up very briefly, the last sort of impetus for this paper was also sort of a call to get women more involved in research for Parkinson's disease so we can better address some of these issues that we just discussed. And with that, I'm going to turn it over to Dr. Subramanian to discuss sort of the 15 things women should know about Parkinson's disease. And you can find these on the blog here.
Thanks, Adrienne. So I think we can, go to slide 1 if that's okay. So I think it's important to get educated. So I think you're here making the first steps of towards trying to learn more. And I think, getting education as empowerment is a huge key to sort of being able to, approach your physicians with the knowledge, and you want to make sure that the knowledge is vetted. So you want to get good sources of information. And so number one, letting people know that women can get Parkinson's. Again, Adrienne talked about the image that's been propagated of this old white man, and we've done a good job of teaching our students about that image. And people really, when they see somebody that looks like me or Adrienne, really don't think about this in the differential diagnosis of very common presentations with tremor, stiffness, and slowness. People are often misdiagnosed, and the diagnosis goes missed for a number of years. And some people are told that they have anxiety or mental health issues, refer to the wrong practitioners, sometimes even put on the wrong medication. So I think, again, learning about this disease, knowledge is power. We've listed a number of great resources here, and our blog run by Mike Oken, I think, is a great source of information as well. It's important to realize that Parkinson's is not just a motor symptom, as Adrienne had talked about. The sort of classic way that we educate our students is around these the mnemonic TRAP: tremor, rigidity, akinesia, and postural instability, really focusing on the motor symptoms. And so if your doctor is a primary care doctor, or sometimes a mid-level sort of nurse practitioner, PA, that has had not as much training in the neurology field, often this motor sort of aspect is really the only thing that people remember from their medical student training, and really miss the fact that this also has a huge amount of non-motor burden. And often these non-motor issues, as well as the mental health issues that we list here, anxiety, depression, apathy, sleep difficulties, are so common and often affect quality of life in a much broader and more impactful way than the motor symptoms. And so really, I think we've often missed teaching around this. And so it's important for you to learn about these things so you can bring these to the attention of your doctor. Also, I think historically, we've not done a good job of talking about the hormonal cycle. And as Adrienne pointed out, going into the week of your menstrual cycle or going through menopause can really affect women with Parkinson's pretty dramatically. And so it's important to bring that to the attention of your doctor. And we put that image in there, and now people can download that article and print it out. And we've actually handed that out to some of our patients as well, to sort of help them get educated and educate their primary care doctors and other providers. Next slide. So I think it's really important to understand that we have access in our country here in the United States to movement disorders, but this isn't complete access. So we are a very subspecialized field, really a lack, even in the US, of good representation. I actually met the only movement disorder neurologist. I just came back from the American Academy of Neurology. I met a movement disorder neurologist who is the only movement doc in all of Montana, and he actually has a huge catchment area of a number of states around him. And it's a huge, tremendous sort of burden for some of these rural areas to find good subspecialty care. Now with telehealth, I think we've expanded the ability to seek out some of this. But I think if sort of there's a sense again that women often are not putting themselves first and have to then drive or seek out care that's sometimes not easy to get, I think you want to put yourself first, try to find ways to get access, even if it's once a year, to check in with a movement disorder specialist. And really, I think the times to do that are at diagnosis, to make sure that you're on the right path, that you have the right diagnosis made. And then at these sort of key points that we point out in this list, sort of if you're thinking about getting pregnant, before you get pregnant, get pre-pregnancy counseling with a movement disorder neurologist who can work with an OBGYN to help you through your pregnancy, if you're having menstrual exacerbations, and also in that premenopausal timeframe, because it can sometimes require some adjustments of medicines and special advice. It's also important for you to advocate for yourself. So I think in this day of telehealth, often, we're able to capture patients only for a few minutes, sometimes once in 6 months, if you're lucky with the subspecialist. So anything you can do to advocate for yourself. So write down your complaints so you don't forget them, bring in all your pill bottles, write down what refills you need, figure out who the other providers are so that those notes can be sent to them. So often bringing in an advocate is also helpful. So there's an extra pair of eyes and ears. And as Adrienne mentioned, often many of our women come in unaccompanied because they just don't want to burden anyone. But even bringing in a friend or a sister, can really help with that extra pair of eyes. And you want to look at that after visit summary if somebody's printing it out or handwriting it for you, to make sure that you understand your plan of care. Ask questions before you leave leave the visit so that you can clarify what sort of the plan is. You also want to find a provider that you feel is listening to you. And I think, having this paper and sort of these diagrams showing these different menstrual cycles and various timeframes and how they can impact women, as well as the sort of symptoms, has allowed patients sometimes to feel that they have a document around which they can talk around some of their symptoms. So I think, many of the women that have looked at this have felt sort of seen and heard sometimes for the first time. And I think this group here connects women so that you can feel like you can discuss things maybe here and then take things that you may have felt alone with before, get validation from other women, maybe dealing with the same issues, and go find care and feel heard. So I think that's also very important to get a doc that you can feel a good rapport with. And remember that we are, just one of your providers as movement disorder specialists. So there's a number of other folks that can advocate for you. And it may not be somebody who's obvious. So sometimes even a spiritual leader or a sorority leader or somebody else who, can really advocate in some ways and listen to you and be part of your therapeutic team, yoga teacher, who knows who it is in your life. But think about those people who have this role and maybe involve them in your care as well. Next slide. So we mentioned the sort of sense that women don't put themselves first at all. Often they put themselves last. I know Adrienne and I are guilty of this as well. And I think this is just, part of being a woman sometimes in our society, and culture often has something to do with this. So women of color often are even more at risk for this. So take care of yourself. Think about that oxygen analogy. You can't take care of others unless you take care of yourself. Put that oxygen on you first. And wellness is important. So when we think about wellness, what are those proactive things that you can do for yourself every day to make yourself feel better? Think about the sort of things like exercise, finding ways to schedule this, put it on your calendar, find ways to put even things like yoga on your calendar, just like you would a doctor's appointment or a doctor's appointment of a loved one. Really put that on your calendar. If you don't do it, it's not going to happen. So what brings you joy? What brings you meaning? Think about those things and find out what really can fill your teacup. And then, as Adrienne mentioned, I think women are at particular risk of fractures and having poor bone health. And so finding ways to take care of that as well is important. Scheduling those appointments with your regular doctor to get in and checking your bone health is very key. Next. And then Sharon mentioned the fact that we've really been emphasizing social connection. This has been a huge part of my recent research and advocacy work, is really thinking about ways to connect my colleagues to others. And I really do believe this. I live this every day. I am a huge fan of finding a sister, a best friend to talk about things with. Finding who your cheerleaders could be. And I think it's really important to realize that if you're a woman living with Parkinson's, that advocate for you may not be your spouse. Many of the times it's somebody outside of the home. It might be somebody who's your sister or a neighbor, your best friend. And so really think about that early on in your disease. Who's going to really hold your hand, be the shoulder to cry on when you need it, and engage that person and open up to them. And you might even find that person here. You also need somebody who might be a tribe, so sort of somebody to laugh with, to play with, to really share life joys as well as adversity with. So it's really important. And being part of a support group here, I think, is one of the first steps. And I think we've listed a number of other support groups. And I think women have found each other through social media and other online engagement. And I think it's, part of one of the few silver linings that we can really thank this horrible, horrific pandemic for, is really being able to connect with people on a global level. Last but not least, participating in advocacy and research. And so Adrienne showed you the fact that women are really underrepresented in research, and we need to hear your voices. And so getting involved as you can so that we can really change the dialogue from just focusing on white, affluent, older men with wives. We need to focus on how you can be part of that change. And really, when you're part of a change, when you get this purpose, I think Sharon is a beautiful example of someone who had this energy and has sort of taken it and put put it into a positive sort of way of pivoting from something that was a life-changing diagnosis that was, very sometimes negative at the beginning, to trying to find ways to sort of help other women, other people living with this disease, and sort of, I think, gotten new meaning and empowerment through that. So hopefully we can inspire you to do the same. So I think now we're going to open it up. I think Adrienne and I are here to answer questions and, maybe, see where this takes us. So I see one, Adrienne, on in the chat here on bladder Botox for urge incontinence. Do you have a thought?
Yeah, sure. So Botox has all kinds of applications beyond wrinkles. And in my practice, I do use it for symptoms like dystonia and Parkinson's disease. A urologist, so a specialist in the sort of genitourinary system, sometimes uses Botox into the bladder muscle for people who have very overactive bladder, which can certainly be part of Parkinson's disease. And this can be very effective, but I think you want to make sure that you, before you're considering an invasive procedure, that you have a good understanding of the alternatives. Maybe there might be a medication option. There are sometimes some behavioral strategies that can help reduce urgency. And then also a good understanding of the potential risks of the procedure, and make sure that you are comfortable and trust in the expertise of the person who's offering this to you. But for people who have very refractory symptoms, it can be helpful.
Anybody else?
Check in with your, I was just going to say, it's also probably important if you're thinking about bladder Botox, definitely get a urologist to do it, but to involve your Parkinson's caregiver provider as well, so that they are aware.
Okay. If you have questions, just you can raise your hand or just put it in the chat. Either way, I think that you're making a huge impact in the Parkinson's world, and I really appreciate all that the two of you, that your group of 6 has been doing, and you're speaking all over the place. So thank you.
I can give you just an update or two about some of the energy that's continued to happen, maybe as we're waiting for other sort of questions to come in. So one of the things that, and I know, there's a lot of different ages in terms of the representation of women with Parkinson's, but there's been a huge energy around pregnancy and Parkinson's, and Dr. Oosterbaan, who is one of our co-authors, who's based in the Netherlands, has been very excited to try to get a registry going for women with Parkinson's who are pregnant, and sort of follow them about, if they had pre-pregnancy counseling, if they were on anything special, how the pregnancy affected the symptoms and things like that, how the delivery went, how things happened, how the baby did, and things like that. So she's actually starting an initiative with some folks who are interested in young onset Parkinson's disease in the Netherlands. And I spoke to Dr. Post, Bart Post, who is helping with that. And she's actually working with them in their research group. And so really spending sort of time in the advocacy world and putting it into practice in her, actually now will be part of her day job. So so excited to see sort of where that goes. And she just had her 4th child while being pregnant with Parkinson's, and really is doing well, but has many, many ideas to sort of move that needle forward. But I think in similar ways, thinking about, we've identified a number of needs here, how to sort of engage and move sort of the needle in some way is sort of our hope, is really not to just come up with sort of these doom and gloom scenarios about all the unmet needs, but really sort of to have women connect. And really, I think the patient voice is huge in trying to move this forward. And so we're excited to sort of hear from you all. And I think, the mentorship program has been something that we've been very excited about, because my sort of thoughts around where Parkinson's is, especially in the pandemic, is left with the sense that the non-motor issues, especially the mental health issues, have really been underestimated in terms of their impact. And I think isolation has really been a problem for many, many people living with Parkinson's throughout the world. But when women get together and are able to share some of their thoughts, I think it really validates sort of people's sense of, what's been going on, and makes them feel less alone and less isolated. And then I think, real change can be made once people get together and start discussing things. And I think having sort of the sense of not all care is just in a doctor's office, and sort of expanding the definition of sort of your healthcare and in a more holistic way, and all the people that can impact your health, and sort of thinking about not just, the doctor, not just the healthcare providers that might be physical therapists and allied folks, but also thinking about the community and sort of engaging the community from support groups, and having Parkinson's patients helping each other in some ways is really an exciting sort of wave of the future, I think. And so I'm excited to see sort of where that goes. So,
okay. We have a few questions in the chat, but before we move on the vein you were just speaking, is there any way that we can get out there and talk to neurologists and medical students about, as women with Parkinson's, and say, I have Parkinson's, I am not an old white man, how can we educate them? And you've got all these women who are now advocates, so use them.
Yeah, I love that. So just like I think Indu was talking about the things that suffered in caring for our patients during the pandemic and the issues that it really brought to light, I think also in the education space. So in my other sort of hat at UCLA, I'm one of the associate program directors for our neurology residents. And before the pandemic, we used to be able to have sessions with medical students, residents, where we would bring in patients to share their stories. And I really think that that is a powerful way to learn. And I think as we're getting more and more used to Zoom and emerging to some degree of sort of normalcy with the pandemic, I think I would say if any of you are open to speaking to primary care physician groups, medical students, neurology residents, and sharing your story, sharing your experience. As an educator, that's something I know that I think always makes what I'm teaching more powerful, is to hear it directly from the patient. So I would, if you, even with your own primary care doctor, you could say, hey, are you, part of a local association of primary care docs? I'd love to come speak to your group and share my story. Or, or if you don't mind me bugging you, I can invite you to share your story with our residents and students at UCLA. I do think that, Dr. Subramanian also does a lot of work educating geriatricians who, care for people with Parkinson's disease. So I think we have access to these other groups. And I think you bring up a really good point. It's not just about educating each other and neurologists, but reaching sort of outside of these silos, so that even the lay public is better educated about Parkinson's disease. And certainly, like you said, Sharon, other medical sort of physicians and nurses.
Mm-hmm. Okay, so we have a lot of questions now. So Linda Warren asks about your thoughts on MRI guided ultrasound, which is a question I have too. Where are we with that?
So I'm happy to start the discussion about that, and Adrienne can definitely add. So we've had that technology around. It's largely been around for essential tremor for a little bit, and it is, even though it's thought to be this sort of non-invasive procedure, it's still affecting. The ultrasound is used to modify the tissue and sort of ablate it. It's sort of damaging the tissue in a way where we used to put electrodes in through deep brain surgery to modulate this sort of area. We're actually sort of, putting a lesion in there. And largely it's probably safest just done on one side of the brain. So it's still quite early in terms of the research in Parkinson's disease, but it's been out for essential tremor for a little while. And we get all kinds of referrals for this procedure because I think the advertising has been really great to sort of talk about how non-invasive it is. And people come to us and think, it's a very sort of easy peasy kind of drive-through procedure that's like getting your nails done or something like that. But, in the end, we are still modulating the brain and making a irreversible sort of lesion in there. And often the patients who come to see us, if they're good candidates because their tremor is bad enough, from an essential tremor perspective, we end up doing deep brain surgery on them. And so it's been a kind of a nice referral base for our deep brain surgery surgeon, and not so many patients who end up going to ultrasound. The people who are probably good ultrasound candidates are the ones who can't tolerate probably deep brain surgery for some reason. It's too complex. It's too hard to put in the hardware and things like that. So, but it's a very niche sort of, I think, population. And I think in Parkinson's disease, which is, I think, most of the folks on this call, I think it's still very early, and you'd have to be very tremor dominant and unilateral. So just one side of your brain affected, one side of your body affected by tremor and not much else to really, I think about this for Parkinson's disease. Adrienne, do you have anything else to say?
Yeah, I agree. The technology of focused ultrasound is somewhat new, but the approach is actually very old. Like lesioning the brain is something that they used to do before DBS was invented. And so this is sort of a newer way to do an older strategy. I agree with Dr. Subramanian that I think deep brain stimulation is probably still our best surgical procedure for treating motor fluctuations and tremor. But focused ultrasound can be a good option for those who, for other reasons, can't go through with DBS and have sort of very one-sided symptoms like tremor that we can target with focused ultrasound. But we were talking a little bit about the comb over. With focused ultrasound, you have to shave your whole head. So that's sometimes a cosmetic concern to keep in mind.
A couple more. We have a lot of questions now. Do we know why women are more prone to levodopa-induced dyskinesias? And how about having clinical trials focusing on PD in women?
I'm happy to take the one on, either, but the levodopa-induced dyskinesias. So I think, the metabolism's a little bit different of, levodopa in women, also because of the lower body weight. Women tend to need less probably. And historically, I think it's been a one size fits all kind of prescription. So we educate around using the Parkinson's medications. It's largely been using standard levodopa doses of 25/100 is the one that we usually choose to use of immediate release Cinemet. And we start with sometimes a half a tablet and go up to 1 tablet 3 times a day across the board for pretty much everyone as a starting dose, and then kind of take it from there. And I think that, the sort of need to sometimes micro titrate is harder with that sort of formulation, because you can either just give a half or a whole, and most people end up staying at 1 3 times a day just because that was what they were put on at the beginning, and then go up by increments of something or the other that's sort of standard for what we sort of have historically judged from our studies around, again, white men that are, older. So I think we have to, I think this came out probably with one of the trials that we were involved in, called the STRIDE PD study, where we saw that dyskinesias were definitely higher depending on body mass index. And what ends up happening is sometimes women, because they tend to be on the leaner side, when they get dyskinetic, sometimes there's actually can be weight loss that happens, and then they need less drug as they lose weight as well. And so I think, again, that's probably a good time to check in with a Parkinson neurologist and discuss the issues, maybe look at your weight trends as well and decide how much Parkinson medication you actually need. But that's sort of my sense. Adrienne, do you have any other thoughts?
Yeah, no, the only other thing I'll add is that there are some studies looking at genetic risks for dyskinesia. So there are certain, like the gene, for example, for the dopamine receptor in your brain, there are some different versions of the dopamine receptor that all of us have. And some of those are more prone to developing dyskinesias, and those genes, which are not related to gender at all, can influence your risk for dyskinesias. And we see that some of those genetic factors are also different between men and women. So I think, the risk for dyskinesias is complex. The lower body weight and the metabolism differences are part of it, but also on an individual level, I think your own sort of genetic predisposition to dyskinesias may also be different for women compared to men. So I think we're still in the process of trying to better understand all those factors so we can have a more personalized medicine approach to prescribing for Parkinson's.
One other thing I'll say is that some of the non-motor issues sometimes that are accompanying dyskinesia, so anxiety, for example, sometimes can be higher in women as well in some of the reports. So if you have some of these issues that are also going on, sometimes treating that underlying issue or getting, sort of other wellness strategies, to sort of try to help with those can help with the dyskinesia as well.
Okay. Okay.
And then
let's
the
go-
trials question about trials for women. Yeah, I mean, I think we've just sort of started to really get the fire going with this. And Nacho Mata, who you might have, I don't know, has he come on your program yet, Sharon? Ignacio Mata, he's a really amazing geneticist and, just a lovely advocate for Parkinson's research in general, very invested in especially the Latinx populations, but is doing work throughout the world, very collaborative. He's based in, I think, Cleveland Clinic, or I'm not 100% sure exactly where, but he has a study out now in the Latinx population, looking at genetics and also looking at women and their specific issues, and working with, I think, Compe, the Parkinson's, and some other folks in that population. So I think, after our paper came out, there's been just a number of folks that have really used it as fodder to try to apply for grants and really seen it as an opportunity. So I think hopefully this will, inspire more trials. I think getting organized with which trials are specifically for women and listing those, I think, some of the folks at Parkinson Foundation and other places are trying to, I think, at least start to shine the light on this. But I think many, many trials, even though historically may have excluded, especially pregnant women, are open to women and are actually seeking women, and especially women of certain ethnic groups exclusively, and sometimes will pay for transportation and try to, increase the enrollment of these groups, because I think folks have found that this has been a real negative sort of aspect of how we've conducted research before. So I would definitely, I don't think that you need to necessarily look for a women-specific trial. Just look at any trial, and if you can participate, just sign up. That's what I would say. Adrienne, do you have any other thoughts on that?
Yeah, no, I agree. I mean, I think, I think there are some specific issues, Indu and I were just discussing, many people are asking about hormone replacement therapy, and, and it really would be valuable if we could do a trial prospectively looking at women with Parkinson's and hormone replacement therapy. And that would be a huge, probably, multi-center, if not multinational, international study to try to get enough women to participate. But I think where you can really play a role is, I think more and more people are also looking at outcomes, sort of patient-centered outcomes research. And so having women involved in deciding what are the important research questions, I think is valuable. And so I think, we're here, we can help amplify your voices, but if there are things that you really think are important that you think we need to study, I think that's a really good place to start, saying, we need to know more about this. We need to study this.
You can always send your ideas to me and I will forward them. So, or put them in the chat today.
And I think some of this research has to be done sort of across silos. So, for example, some of the women's issues is going to require an OBGYN that's sort of invested. And I know Dr. Post was mentioning the fact that in the Netherlands, they have a nice center for young onset patients that is trying to use some OBGYNs that are in the hospital. They have some other folks doing the mental health piece, and they're really trying to sort of connect many of these dots. Unfortunately, with some of the way that healthcare reimbursement is in the US, it outside of a clinical trial, a lot of this collaboration doesn't happen very easily in centers, but hopefully we can start to get folks interested. And then there's things like the Women's Brain Project, for example, that are looking at women's issues across a number of neurological diseases. And I think, following their sort of information and Twitter posts and things, and getting signed up for anything that they're also sort of advocating around would, I think, be another place to do research for.
Okay. If you can send me whatever information, I can pass it on, whatever information you have about these things. We've got a few more questions and then I'm going to wrap it up. And if anybody wants to stay on after that, you're welcome to join me for a few minutes. Is there a registry of studies focusing on women? No. And Bonnie Schwartz needs the name of the doctor, the movement disorder specialist in Montana. If you don't have it right now, just send it to me.
Okay. He's in Bozeman. I remember that. I don't know his name. I don't remember his name.
Okay. Women and abdominal pain, gastroparesis and SIBO.
Small intestinal bacterial overgrowth. Yeah. Yeah, so we know that gastrointestinal symptoms are very common in Parkinson's disease, and there's even a postulated link that Parkinson's may start in the gut. And so in one of those sort of figures I showed from the review paper that was published in 2019 by Sari and colleagues, in the women in the pink circle, GI symptoms was more common than in the blue, the men's circle. And so GI symptoms certainly are very common. There are some studies I'm aware of linking small intestinal bacterial overgrowth and Parkinson's disease, though not in a direct sort of cause and effect in a way, but there are some associations with worse GI symptoms and even worse motor symptoms in people who have SIBO in Parkinson's disease. And I think that's an area that probably needs further study, but we know that GI symptoms can have a huge impact on your quality of life, even on the way your medications are absorbed. And so we're pretty, I always, think to myself, when I became a neurologist, I never thought I would talk so much about poop, but I think we're pretty cognizant and pretty aggressive about really making sure we're addressing those GI symptoms, because we know they can have a huge impact on many of your other symptoms too.
Okay. One last question. I love this one. Is a woman long past menopause with PD ever been put on HRT to ease symptoms, or is it too late?
I would say the problems there are actually the risks of HRT in that setting. So when you talk to your gynecologist, for example, about hormone replacement, there's all kinds of other considerations, including risks for breast cancer, uterine cancer, increased risks for blood clotting. So there are other medical impacts of being on hormone replacement therapy, which is usually why it's not considered long after that perimenopausal time period. And so I think from that perspective, that's why we don't just, as neurologists, go prescribing hormones.
I think it's definitely a risk benefit analysis. You want to weigh your risks and talk to your gynecologist, maybe have the gynecologist speak to the Parkinson's doc and figure it out. But I don't think we have great data to support, people certainly after menopause, and there's some controversial data. I think a lot of what we found was very conflicted. So it was sort of like, some studies showed this, some studies showed that. Just to sort of mention the GI issues again. So I think low-hanging fruit for everyone is to, if you have bad constipation, to try to treat that, increase your fiber, drink lots of water, exercise. Those are all good ways to try to help with constipation. And again, if you're not moving your bowels very well, it's hard for your absorption of meds to be good. Eating a good diet with lots of fresh fruits and vegetables, avoiding processed food and things like that is definitely helpful from a bowel movement perspective as well. People have asked about probiotics. I think there's not great data, but prebiotics are things that are going to be good for your gut health in general. So fermented food, lots of, again, fruits and vegetables, things like that are definitely, things. Sometimes yogurt can be helpful, although dairy's been sort of controversial. So I think, again, there's not a lot of evidence, but I think generally, eating healthy, balanced meals with a good amount of fresh fruits and, plant-based sort of food is probably the way to go. So.
Okay. Oh, Linda has one last question about bone medications like Fosamax, Boniva, pros and cons.
So my sense is that you should work with your primary care doctor, but bone health is really important. So I think if there's not a contraindication, it would make sense if you have, osteopenia or osteoporosis to go on those medicines. They're tolerated just fine in Parkinson's. There's an ongoing study right now called the Topaz study that's looking at this as well. So it's definitely something that we are, I guess Adrienne's writing the same thing. Yeah, I think.
I wasn't sure we were going to get to the question, so I thought I would just respond quickly in the chat. But yes,
Yeah.
Exactly.
The Topaz study is, I think, a study that I think is still enrolling and would be a study that you could just probably Google, and I think it would be great for more women to sign up for that. So
Well,
it's
I am now the patient advisor on their advisory board. So if
Cool.
you're interested, email me and I will send you the information.
Sounds good.
Okay, because
Great,
I don't
well-
have enough to do. And you're going to yell at me again, I know. She's always telling me to slow down. I don't want to. Anyway, thank you. I'm going to go back to sharing my screen because it's time to wrap up, ladies. Let's see. Okay, so I'm giving both of you a virtual tiara because we are not in person. It's virtual, and I don't have mine to put on. I forgot to bring it with me. And thank you. This has been wonderful. I think everybody has really, really enjoyed it. We're hoping to have a program on May 22nd. The speaker I had fell through, so I'm working on something. I'm not quite sure what. If you have any ideas, get back to me. Let me know. And then Tuesday mornings, Shelley and Darlene are doing their Anything Goes open mic Tuesday mornings, 9 o'clock Pacific time, 12 noon Eastern time. If you're interested in attending, email Shelley. And they are also doing a Friday morning exercise meetup. So whatever you're exercising on, Shelley gets on her elliptical. I get on my bike, and anybody else that wants to join us, you're welcome to. We just chat while we exercise. And we are looking into a retreat. We've talked about that before. There's a lot of excitement about that. The World Parkinson's Congress is going to be in Barcelona next year, and if you've never been and you want to go, we're going to be offering scholarships for registration. I think we can cover 10 registrations right now. We've raised enough money. And if you're interested in a chat group for women without partners, let us know. That's another thing that people are interested in. And I think that is it.